Thank you very much. It's an extreme honour to be selected for this award, and I thank you all very much for giving me the opportunity to come and talk to you about our research, which is looking at the time of birth and risk of respiratory illness in preterm infants less than 30 weeks gestation, a retrospective matched pair cohort study. So, looking in the recent press in the UK, such as the BBC, and also looking at journals such as the BMJ and large hospitals such as Imperial College in London, if you have surgery, the later in the week that you have that procedure, the higher the mortality. And this in part has led to the findings of a recent public inquiry, the Mid-Staffordshire inquiry, which found excess mortality in a particular hospital in the middle of England. And this in part put down to the care, which, in part put the excess mortality seen later on in the week down to deficiencies in care noted. It's true in adult medicine as well. For example, in this large cohort of patients admitted at the weekend who required cardiac procedures, those individuals were not only slower in receiving that intervention, but also resulted in a greater mortality 1 year on. And the same can also be said for those individuals who are admitted for abdominal aortic aneurysms, epiglottitis, and also pulmonary emboli. Interestingly, when you look at neonatal mortality, it's also been found to be high at the weekends, and this was first looked into by McFarlane in 1978. He also hypothesised, however, that there were more high-risk births at the weekend, and therefore the semi-elective or semi-emergent obstetric cases were perhaps delivered by C-section within the week, thus making the children at the weekend high risk, and therefore perhaps making the weekend service truly on call for emergency cases. And indeed, if you look at later literature on from there, the literature seems to support his original hypothesis. Just a quick display in this table of some of that research, and you can see here, whilst they have differing results, the first study, which has much higher numbers, shows an increased mortality at the weekend. However, could this weekend phenomena be explained by these high-risk features? For example, very low birth weight infants are more likely to be born at the weekend. So we might not be surprised to hear that their mortality rate is higher. But if you compare the mortality rates from the weekend to the weekday, when you adjust for that low birth weight, you can find that there's actually no difference between the mortality at the weekend, born at the weekend, and those infants born in the weekday. If you have a look at the difference between day and night deliveries, however, there's some interesting findings to be found there. For example, in this large study conducted in the UK, the differences in mortality in those infants who are born in day, with mortality rates of 4.2 per 10,000 births, in comparison to those born at night, where we see a neonatal mortality rate of 4.6 every 10,000 births. And interestingly, in those infants who are born during the night, there's an increased odds ratio of dying due to intrapartum hypoxia of 1.71. Again, displayed in the table format, if you have a look at the other literature which has looked into this particular phenomena, you can see the vast majority is showing that there's increased neonatal mortality in those infants who are born throughout the night. So, where does the problem lie? In the UK, could it lie with midwifery care? For example, from the 1980s to the mid-2000s, there's been an exponential rise in the amount of medical staff there that has been employed in the NHS, whereas over that period of time, if you look at the amount of midwives who have been employed, that's remained relatively stagnant. Could it be something to do with the way the obstetric care is delivered? For example, within the UK, there's now increased consultant presence on the ward, which perhaps means that those specialist trainee doctors aren't getting the hands-on experience that they once were getting before. And therefore, when they're left to the on-call service at night, they might not be able to recognise that sick infant that needs expedited delivery. Or could it be something to do with UK neonatal care? For example, manning the rota during night shifts has typically been difficult in the UK in attracting regular staff to neonatal units, thus meaning that continuity of care might be continuity care might be difficult to deliver. Or could it be something completely different? If you look at those individuals who work at night, you actually, and you compare their performance to compare their performance in terms of performing clinical procedures or certainly fine tasks, it's the equivalent to someone who's gone out and drunk a couple of pints of Brighton Best. So it may well be that we're just not, as humans, we're not very good at working at night. Interestingly, researchers began to look elsewhere now and beginning to not only focus on mortality but also on morbidity. If you have a look at this study from Australia and New South Wales, they looked at developmental outcomes in those babies who are born at night in comparison to those born during the day. And they certainly found that there was no difference in neurodevelopmental outcome between each of these cohorts. So we felt, as a unit, we needed to have a look in more detail with regards to respiratory morbidity and time of birth. In particular, with now guidance suggesting that a less invasive approach to managing infants from a respiratory point of view, we wanted to see whether the time of birth had an influence upon their respiratory morbidity. So the aim of our study was to assess the time of birth and its relationship to respiratory morbidity in newborns less than 30 weeks gestational age, born in a single tertiary centre within the UK. Our methods were that we did a retrospective matched pair cohort analysis of preterm infants less than 30 weeks gestational, born in a single tertiary centre between the years of 2006 to 2012. Patients with congenital anomalies were excluded, and patients were grouped according to whether they were born in the day, the hours of 8 a.m. to 8 p.m, or the night, the hours of 8 p.m. to 8 a.m. on any day of the week. We matched each of the cohorts for maternal ethnicity, maternal age, whether they received a full course of antenatal steroids, vaginal delivery, whether they were singleton delivery or not, their gestational age, their birth weight, their gender, as well as 5-minute APGAR scores. Our outcome measures were intubation and surfactant at birth, the length of first mechanical ventilation episode, the total length of mechanical ventilation, the length of non-invasive respiratory support, incidence of pneumothorax, and oxygen at 36 weeks corrected gestational age. Excuse me. We also had our 7th outcome measure was that of postnatal steroids. So I'm just going to take some more time. Data was either extracted from the patient notes or from the unit's paperless computer system. Qualitative data was analysed using the chi-squared test, and quantitative data was analysed using the Mann-Whitney test, with a p-value of less than 0.05 considered significant. In terms of our results, we identified 362 infants which we could include in this cohort study. We had to exclude 36, either due to congenital anomalies or incomplete data, leaving us with a final cohort of 326 infants to be included in our analysis. When you have a look at the descriptive data and what we matched for, there was no significant differences in the ethnicity, maternal age, whether they received a full course of antenatal steroids, the type of delivery, and also whether they were a singleton or not. Again, when we looked at the other descriptive variables, we could find no significant differences between gestational age, birth weight, their sex, or 5-minute APGAR scores. When we had a look at the outcome variables, as displayed in red here, we found significant differences between those infants born in the day versus those born in the night with regards to intubation and surfactant and the total length of mechanical ventilation. No significant differences were found in length of first mechanical ventilation episode and also the length of time those infants spent on non-invasive respiratory support. Again, looking at our further outcome measures, only a significant difference was found between those infants born in the day and night with regards to rates of BPD. Again, no significant differences were found between pneumothorax, postnatal steroids, or the overall mortality of those infants. So when looking at these results, we felt that we could clearly see that the clinical management and delivery affects overall respiratory outcomes. But interestingly, the time of birth affects respiratory management and therefore goes on to affect that subsequent neonate's respiratory morbidity. But we wanted to postulate the reasons why this may occur. And we felt that one of the key things was clinical decision making. And we felt that there was 3 things which are quite interesting to look at, which influence that. For example, knowledge. Within the UK, all registrars or trainee doctors who are considered to have the ability to man a tertiary neonatal unit at night will have passed the Royal College examination. So therefore, will all have a certain standard of knowledge with regards to neonatal care. However, within that cohort of doctors, there's going to be a bell-shaped distribution to that, and there's going to be certainly an awareness of the various guidance which is available, which is going to differ between trainees. In addition, training within the UK has changed quite a lot. With the advent of modernising medical careers, it has meant that perhaps a focus on a more hands-on training has now changed to more of a competency-based training. In addition, experience varies. As previously alluded to, you have to have passed the Royal College examination to be considered the most senior doctor to man a tertiary neonatal unit, but the experience of that trainee may be different. For example, you may be 4 years into your paediatric training and be manning that tertiary neonatal unit at night, or you may be 8 years into that training and just about to qualify as a consultant neonatologist and still be considered the most senior person at night to man a level 3 neonatal unit within the UK. So, as alluded to, the staffing and experience on the UK units vary. There's also been a number of concerns over this period of time as to the impact of the European Working Time Directive, not only from a continuity of care point of view, but also as to its impact on paediatric trainees' ability to see enough pathology in order to progress in their training. Interestingly, when you look at the US, when duty-restricted hours were placed on residents and fellows in neonatal units, they found that the neonatal morbidity and mortality in the cohort of study that they investigated was not different in very low birth weight infants before and after those restrictions were put in place. So therefore, it sort of makes sense that you would want the most experienced doctor to be at the delivery of a child to ensure the best outcome from the respiratory point of view. And indeed, the Royal College in the UK is trying to address this with these two documents, which allude to the fact that they want higher degrees of consultant care at sort of the coalface, or, for example, in the delivery room. However, this may all pale into insignificance when you consider the abilities of a clinician to work at night. For example, this study here by Rothschild et al. Found that in America, when attending physicians came in to perform a procedure, that those procedures were much more liable to complications than those procedures which were when they were performed in the day. So going back to the strengths of our study, we felt that that its particular strengths was that most of the previous research has been population-based and maybe less able to control for confounding variables. Also, prior research mainly focuses on term babies and also mortality, whereas this is the first study specifically focused on respiratory outcomes in preterm infants with regards to their time of birth. Its limitations is inherent to its methodology. It's retrospective, it's single centre, and it's UK-based, and therefore might not be reflective of wider practice in Europe or throughout the world. In addition, data collection is also at risk of recall bias. However, the conclusions we felt we could draw from this study is that infants and nights were more likely to be intubated, given surfactant, be ventilated for longer, and subsequently develop BPD. But we also felt like it raised some very interesting questions for neonatal care within the UK. Firstly, that in the time of austerity and significant changes to the paediatric service provision, how do we ensure the best respiratory outcomes for newborns born at any time in the UK? In addition, this study highlights the need for further research in order to explore whether our results are reflected in other tertiary neonatal units in the UK. I thank you for your attention, and I welcome any questions.